My friend and colleague Kelvin Pina. Kelvin, do you hear me?
Hello, everyone. I'm Kelvin Pina. I'm a neurosurgeon from Asturias, Spain. I'm dedicated mainly to biportal endoscopic spinal approaches. It is a pleasure to be able to share with all of you, my dear colleagues, teachers, and friends. I would like to extend a special thanks to my dear friend and colleague, Dr. Valentin Pankowski, for the invitation to this excellent event. Today, I will summarize the literature and my own experience, which has helped me to reduce complications and save time. I hope it will be helpful to young surgeons starting out in endoscopic spine surgery. I look forward to continuing to learn from all of you at this fantastic meeting. UVE is a novel, minimally invasive technique designed for treating a variety of conditions like lumbar spinal stenosis and disc herniation. The procedure utilizes two portals, optimizing visualization and instrument manipulation, which leads to more effective and efficient surgeries. UVE offers theoretical and practical advantages compared to traditional uniportal endoscopy, including that the procedure utilizes typical spinal equipment that should be readily available, require less capital cost and optical instrumentation, and provides greater operative flexibility as a result of utilizing both a working and a view portal. Before I get into the core of my presentation, we must take into consideration preliminary critical points in UVE. For example, for me it's very important the selection of approach site, the position of skin and facial incision, and my personal preference in order to maintain the clear outflow of water is to make a cross incision in the fascia. It's very important to make a proper triangulation and use serial dilators and blunt passing. In relation to approaches for lumbar hernias and stenosis, in most cases, the two incisions, in the majority of cases, should be separated by 2-3 centimeters and 1 centimeter from midline. Regarding general principles of UVE, it's very important that take into consideration that spinal anesthesia has emerged as an alternative to general anesthesia and has been increasingly used in lumbar spine procedure of limited duration, less than 3-4 hours. Personally, I feel very comfortable using awake spine surgery with regional anesthesia because it's easy and is preferably in my case for short time surgeries. For ergonomic purposes, although high adjustment is possible in most tables, use of a platform can be complementary. Proper high adjustment allows surgery to be performed without shoulder abduction that can cause fatigue and physiologic tremor during surgery. Also, it's very important to take into account the patient positioning. If the line from the back to the pelvis is horizontal to the floor as much as possible, triangulation is easy and so you can prevent complication of wrong level surgery due to the tilt approach. The abdomen should be free to avoid venous bleeding. Elevate proximal side of the table 10-15 degrees approximately. It's very important to flex the 30 degrees the knees, favoring a concord position like I show in the image. Be aware of keep systolic blood pressure around 100-110 is crucial for minimizing bleeding during surgery. This careful monitoring can enhance visualization of the surgical field and prevent complications linked to excessive bleeding. Light cable, suction tube, and camera cable should be properly tied so they don't come into the field during the surgery. Let me give you some techniques for successful outcome. This is very important to make a proper muscle detachment. Utilizing a detacher prior to endoscope insertions expose the bone surface and minimize visibility issues caused by soft tissue, streamlining the surgical workflow and reducing time spent on debridement. It's very important to make a patent water flow. Maintaining a constant flow of saline is vital for optimal surgical visibility. So, increasing the saline pressure by raising the saline bag or squeezing the saline bag is not recommended. Blocked flow can lead to increased pressure and blur operative fields, resulting in muscle edema and complications such as increased intracranial pressure, delayed recovery, or headaches post anesthesia. It's very important to achieve sufficient bone resection. When using scissors and burr, be aware of the width in advance and perform sufficient bone work from the beginning. If the ligament flavum is removed first, the risk of additional laminectomy is increased and it may be time consuming and not enough decompression. This is very important. Take this part or this step into consideration. Be aware of the dura during bone drilling. This is very important. To avoid complications, it's very important to monitor during procedure every aspect of your patient. Continuous monitoring throughout the procedure is vital to ensure patient safety and surgical effectiveness. Observing vital signs and maintaining hemostasis are critical to promptly identifying complications, allowing for swift corrective actions that enhance overall outcomes and recovery time. In UVE, particularly, it's very important to be aware of the complication or potential. In sum, the main complications include dural tear, epidural hematoma, incomplete decompression, transient neurological complications, and increased intracranial pressure. In a recent meta-analysis research published by Chen et al. In 2023, the total complication rate of UVE for stenosis was 8.1%. The most studied was on dural tear with an incidence of 4.5%. The epidural hematoma postoperative was reported with an incidence of 1%, and incomplete decompression was reported in 2%. According to Lee, in recent studies, the reported complication rate of UVE discectomy was 0 to 23.6%. Based on dural tear classification and prevention strategies, King et al. Proposed a classification for incidental dural tear in endoscopic spinal approaches. The author divided dural tear as follows: Type 1 nerve root sleeve tear, Type 2 dural tear central, most of time of 1 centimeter, Type 3 complex dural tears. These are regular or irregular incidental dural tear injuries more extensive than 10 millimeter, and Type 4 unrecognized dural tears. If they are symptomatic, then the defect should be explored and repaired. Strategies to prevent dural tear or incidental dural tear is basically to take careful selection of patients and the approach. B. Take into consideration the outside-in technique. Use a good endoscopic vision to avoid blurry vision and avoid complication. Use sharp instrument and be face away from the dura. Although symptomatic postoperative epidural hematoma is relatively rare, it can lead to serious consequences such as Code-Kina syndrome and even lower limb paralysis, which affects patients' quality of life. Therefore, early detection and handling are very important. Reduce the operation time and maintain the pump pressure below 40 millimeters of mercury. In my experience, applying bone wax, epidural Fogarty balloon, and gelatin thrombin matrix sealant is very effective. Copious irrigation and intermittent blocking of irrigation will be very effective also. In the case of severe spinal canal stenosis, a custom osteotomy of the bilateral superior articular facet should be performed, as well as a laminotomy of the upper edge of the inferior lamina, resecting the final part of the yellow ligament. In many cases, after a spinal biportal operation, some patients may show some stenosis in inferior part close to the superior border of the inferior lamina. And this is due to a remnant of flavor ligament that lies below or behind the anterior face of the inferior lamina. My opinion, final reflection that I can give you, and based on evidence and personal insight, the most important steps are that the optical hydrostatic pressure can be between 30 to 15 millimeters of mercury. The bag is 15 to 70 centimeters above the patient back. Make proper triangulation. Use the outside-in technique. I recommend that bone work using the endoscopic drill should be completed before complete removal of the ligamen flavum to reduce the risk of durotomy or neural tissue injury. I use the curette to perform part of the contralateral sublaminectomy, the medial facetectomy, and flavectomy after high-speed birth, because most of our patients are osteoporotic, and in many cases, this is a kind of advantage. Be aware of the ocean bleeding, and it can be controlled with bone wax, tamponade pressure, or in many cases, high-speed bore. Thank you all, dear colleagues. Let's continue sharing our knowledge.
Dear Kelvin, thank you very much for an interesting presentation. It is very sad that you could not chance come to Ukraine, and we hope that we will see you in the nearest future, maybe in Zurich or in another ISMIS symposium. Thank you very much.